Mark, thanks for so much for giving your time to this. I know you're very busy and you're constantly being asked to do all sorts of interviews. So thanks for that. For everybody at home, why don't you just sort of introduce yourself, who you are, list your credentials, and we'll take it from there.
Sure. So thanks for having me on, Sam. My name is Mark Horowitz, and I'm a trainee psychiatrist. I currently work as a clinical research fellow at North East London NHS Trust, and I'm an honorary research fellow at UCL. I run a deprescribing clinic out of North East London. I've done a lot of research in the area of how to safely stop antidepressants and the withdrawal effects people experience. I wrote the guidance for the Royal College of Psychiatrists on how to stop antidepressants. Some of my work contributed to the NICE guidance that tells doctors how to stop antidepressants, and I'm preparing a learning module for prescribers in England, asked for by Health Education England, to educate doctors on how to safely stop antidepressants.
Brilliant. Well, thanks for again coming. So let's just get into why I wanted to speak to you, which is about antidepressants and particularly the withdrawal effects when coming off antidepressants. So, and I know that there is a personal link to this and why you were interested in this in the first place. So why don't you we start with that?
Sure. So probably like a lot of people in this area of research, I've got a personal reason to be there, which is, I started taking antidepressants when I was 21. Like to say, I'm a bit of a miserable character, the sort of character you might find in a Woody Allen film. I started them and I took them for many years, and I tried to come off them. Actually, as I was writing up my PhD at the Institute of Psychiatry, Psychology and Neuroscience at King's, I'd read a paper about withdrawal effects from antidepressants at the end of my PhD, and I found that very startling because I'd never heard about withdrawal effects from antidepressants in medical school or in my psychiatry training or my academic work. And I found it startling because the drugs that I know that cause withdrawal effects are drugs like opioids, OxyContin, or benzodiazepines like Valium. And those drugs are drugs you become tolerant to because tolerance is the flip side of withdrawal, and they're often not that good for you in the long term. So it made me think perhaps I should try coming off antidepressants. And I did. I came off over about 4 months after being on them for almost 15 years. I halved them several times, and I ended up in the worst state of my life. I had trouble sleeping. I'd wake up with full-blown panic, and that panic would last for hours and hours and hours of the day, and it would settle a bit in the evening. I took up running about 10 kilometers a day because it gave me a bit of reprieve. I ran until my feet bled. And after week after week after week of those symptoms, I thought I can't keep doing this. I thought I can't keep living like this. Notably, this was nothing like the symptoms that had put me on the drug in the first place. I'm a pessimist. I'm a miserable character. I was worried about my choice of degree, but I'd never had panic attacks, trouble sleeping, or symptoms this severe in my life. In the end, actually, it was so destabilizing. I ended up moving back from London to Australia, to Sydney, where I grew up. I went back on the medication, even a little bit to a higher dose, which eventually settled things. And at that point, I sort of was aware I'm now taking this medication because coming off it is so dangerous to me. It's so the withdrawal effects are so severe, and I kept taking it for several years afterwards, and now I'm coming off it in a much slower way that I'll talk about further. And that was my introduction into the withdrawal effects of antidepressants. And then second of all, my first thought was, I'm a very unlucky person. I've had this very bad reaction, must be very rare. But what I soon found in looking online, as you do, in peer support forums, on different Facebook groups. First of all, I found dozens of people with similar experiences, severe withdrawal effects, much more severe than their original symptoms. Then I found hundreds of people, and eventually I found tens of thousands of people on different groups, and realized it wasn't just me being unlucky, but it was a much wider spread phenomenon. And that's what's really drawn my attention to the issue. The difference between what people experience and what the textbooks said at that point, and what doctors advise people to do, is what really drew my attention to the area.
Wow. Okay. So that's a lot to digest, because I'll share as well. So I had a horrible postdoc, and I thought I had sort of depression. I know I had a sort of probably chronic stress. I even had the shingles at one point because I was so run down. I was commuting back and forth from the Midlands to London every day. And my go-to was to speak to my GP for some antidepressants. Now, I guess that would be the thought process for many others, in that antidepressants are sort of seen as the go-to frontline treatment for depression. So I guess my question is that how is it that antidepressants, given that they have quite severe, unpleasant, to say the least, withdrawal effects, how did they become an established sort of frontline treatment? Is there an evidence base for that? Is there a underlying theory as to why we have antidepressants?
Right. So it's a very big question. I'll try and answer as much as I can. So, you're right. I think most people have it in their minds that a first-line treatment for depression is antidepressants. It's always been in the NICE guidelines. At the moment, the NICE guidelines say for mild depression, antidepressants shouldn't be the first-line treatment unless someone prefers it, wants it. There are a variety of non-drug treatments. For moderate and severe depression, antidepressants is one of about 10 different options as a first-line treatment. And it's certainly the treatment that doctors are most used to providing. So, of course, CBT and therapy are other options. But we know each year in England that about 8 million people will receive a prescription for antidepressants, and about 1 million people, I think is the last data I'm aware of, people will get CBT from the improved access to psychological therapy, which I think has a different name now, talking therapies. So more people will be given antidepressants than therapy or other options. It is in the NICE guidelines, and the NICE guidelines is based on evidence. I would say that the evidence is much more methodologically fraught than most people understand. So maybe I'll talk through it, although it's a little bit of a mini lecture, so feel free to interject. Maybe I'll start actually at the end and then go back to the beginning. And the end is the reason why antidepressants are recommended to be taken in the long term, so not why they're started, but to be taken for several months or a couple of years, is because of relapse prevention studies. And these are studies, and I focus on this because this is, the most contested area of antidepressant use is long-term use. There's also arguments about short-term use, but let's talk about long-term use to start with, because we know now, I think from the recent BBC investigation, that I think 2 million people in England are on antidepressants for more than 5 years, so quite a large group of people. And so the evidence for long-term use of antidepressants is from relapse prevention studies, so-called. And those studies involve taking a group of people who have responded to antidepressants, so they've improved their symptoms. It's already a selected group of people. It's not everybody given antidepressants. And they're divided into two groups, randomized. One stays on their antidepressants, and the other group will come off their antidepressants, the discontinuation group. And they're followed up for about 6 or 12 months in a variety of studies. About 30, 40 studies have been conducted so far. And they will be given depression scales, things like the Hamilton Depression Scale, how are you sleeping, what's your mood like, do you feel suicidal? And there's a certain cutoff above which you're defined as having depression. And they will look at what proportion of people in each of those arms, either staying on the drug or coming off it, will meet the criteria for relapse over about 12 months. And to summarize a very famous meta-analysis in the Lancet, about 40% of people who stay, 40% of people who come off the drugs will relapse, and 18% of people who stay on the drugs will relapse. In other words, more people who come off the drug will relapse. It's about double the rate of relapse. And so the argument goes, more people who come off antidepressants will relapse, and therefore you should continue antidepressants long-term to prevent relapse, like a prophylactic treatment. The issue with that, with those studies, is one of the main issues is how quickly people are taken off their antidepressants in the studies. So there's a famous meta-analysis by Geddes, published in 2003 in the Lancet, and in that study, the most common way that people are taken off antidepressants is abruptly. That means in one day. You're taking it for several months or years, and you stop it in one day. The average period of time that drugs are tapered for is 5 days. Now, the reason why that's important is I've just mentioned withdrawal effects. I mentioned my withdrawal effects after coming off the drugs over 4 months. So 4 months was much too quick for me. 1 day is, of course, much quicker, and 5 days, the average is also very, very quick. We know that withdrawal effects from antidepressants include psychological symptoms, things like lowered mood, anxiety, crying spells, panic, trouble sleeping. I had some of those. We know that because they're documented in studies of healthy volunteers coming off antidepressants. And that's why we know it's not an underlying mental health condition, because it's demonstrated in people without a mental health condition. So the reason why that's and we also know a few other things about withdrawal effects. One is they can last for a while. So for example, it lasted for me for several months until I went back on the medication. And we know from other studies that some people can experience withdrawal symptoms that last for weeks, months, and even years. Talk about why that is. It's probably because of long-lasting changes to the brain that take a while to resolve. And the time it takes for the brain to get used to there being less drug is what explains how long those symptoms last for. Going back to those studies, you can see how if people are having withdrawal symptoms, low mood, crying spells, trouble sleeping, they're going to score quite high on those depression scales, because the depression scales are saying, are you sleeping? What's your mood like? And in that way, withdrawal effects can be misdiagnosed as a relapse. So these withdrawal effects can be misclassified as a relapse. And so people can mistake withdrawal symptoms for someone having a return of their depression or anxiety. We know this happens in clinical practice all the time. Patients tell us this in a variety of surveys. There are even studies where people have been taken off antidepressants and they've had withdrawal effects measured and depression scores measured, and you can see they both go up over a few days. And when you give them back the drug, they get better. So in simple terms, that 40% of people who relapse coming off antidepressants, a portion of it may be explained by withdrawal effects being misclassified. Various authors have estimated how big that the contribution by withdrawal effects might be, and it may be a half of all those relapses. And that explains the entire difference between the group who stay on and the group who come off. In other words, these studies which are purported to show relapse prevention properties may simply be showing that antidepressants prevent withdrawal effects from coming off antidepressants. To use a slightly crude analogy, but to make it very clear to people who are not familiar with this, it's a bit like saying, if you take a group of smokers and randomize half to continue smoking and half to stop smoking and measure anxiety scores, and you find that more people who come off cigarettes meet the criteria for anxiety, you would then conclude people should keep smoking cigarettes in order to prevent anxiety. You can see how it's a very, counterintuitive interpretation, because you're ignoring that these are withdrawal effects. And so some authors have suggested that that's what's happening with these relapse prevention studies of antidepressants. And so that's why I think the evidence on which the long-term use of antidepressants is flawed, because of the way these studies are conducted and interpreted. I should just briefly mention, there is a better study that's been done more recently called the ANTLER study, published in the New England Journal of Medicine. It's better for a couple of reasons. One, it tapered people off antidepressants over 8 weeks, not 5 days. And two, it measured withdrawal effects. However, the guidance now recommends that people on long-term antidepressants should taper off over months or longer. So 8 weeks is still very quick. And although they measured withdrawal effects, they didn't take it into account when measuring relapse. So they did the same thing as other studies. They used a relapse measurement tool, slightly different from the HAM-D, called the CIS-R, and they didn't exclude people who had withdrawal effects. And so they've come to a similar conclusion about a doubling of relapse with the same methodological problems as previous studies. So we still don't, because the real study to be done would be take people off their drugs slowly enough to not cause them withdrawal effects, and then compare them to people who stay on the drug. And then if there's a difference, then you could say you're demonstrating relapse prevention properties, but that study has so far not been done. So feel free to cut me off, or I'll just keep going.
No. I think let's just pause for a second, because I want to just make sure that because my fear is that there will be an audience running at 2 different speeds here. So there will be those sort of academics that kind of know a lot of the terms that you've used, and then those who are not conversant with it. So let's just start from the basics. We don't need to go at painstaking speed, but in terms of antidepressants, what exactly do you mean? Are you referring to just SSRIs, so serotonin reuptake inhibitors, or is there a whole family that you're sort of referring to?
So in current practice, the most common antidepressant classes prescribed are SSRIs, selective serotonin reuptake inhibitors. The most common drugs prescribed in England today are sertraline or citalopram. Sometimes SNRIs, so that's serotonin or adrenaline reuptake inhibitors, and the most commonly prescribed one in England is venlafaxine. The brand name is Effexor, sometimes duloxetine. Mirtazapine is another drug from a different class called the tetracyclics that's often prescribed. There's an older class of drugs called the tricyclics, which include amitriptyline, and some of the studies that I mentioned look at all of those different types of drugs. So tricyclics, SSRIs, and SNRIs. That very last study, the more modern study that I mentioned, the Antler study, looked at SSRIs, and from the top of my head, I think it was mirtazapine as well.
Right. So, and I guess the bulk of the evidence would be around SSRIs.
Yes,
so
definitely.
Okay, so that let's move that then. So I think that's one thing made unambiguous. The other thing is the short term versus longer term, and I guess my question is I guess it would be more common for people to be on antidepressants in the longer term, because depression is often a protracted, unpleasant condition without this issue with withdrawal effects. And I think just to sort of touch on and frame a different way of what you said. So I guess from a person's perspective, they take the drugs, they seem to be sort of level again. They seem to be improving with the drugs. And then I guess their immediate thought would be, well, maybe I don't need them anymore. I come off them. And then they get all of these unpleasant side effects from coming off them. And then to a GP, I guess, or even to a lay person, they would think, well, this proves that I need to go back on to the antidepressants, and so therefore extending and protracting their use beyond what would be best for them. Is that a fair?
Exactly. So that's you've outlined the story. You're sort of I'm talking in high level conceptual studies, but yes, on the ground, that's exactly what it looks like. So maybe I'll color it out for you a little bit more, because I guess that's what people out there will be experiencing. There's about, as we speak, there's about 160,000 people who are on peer support sites getting advice on how to come off antidepressants. And we've surveyed them in we've published a few papers on that now. We've surveyed about 1,400 of them. And they all tell the story you just told. Something happened in their lives. They took antidepressants. Some of them found it helpful, some of them not helpful, some of them not sure. They took it for a few months or a few years. They wanted to come off it for a variety of reasons. Common reasons are feeling emotionally blunted, not feeling their emotions as they normally would, side effects like weight gain, sleep problems, memory impairments, or something else. There's a variety, or just not wanting to be dependent on a drug, or something's changed in their life. They finished their postdoc, they finished medical school, they've changed relationships, whatever it is, or they've learned a new technique, mindfulness or CBT, whatever. They've got lots of different reasons. They go to the doctor. The doctor says, I'll check the NICE guidelines or the American guidelines. It says you can halve the drug over about 2 weeks, halve it again for a couple of weeks, and then stop it. And they go home, they say, all right, they split the tablet in two, take for 2 weeks, do that again for another 2 weeks and stop it. And then they end up in a world of pain, some of them, not all of them. Some of them have no trouble. Some of them walk off with no issues. Some of them experience what I experienced. It's probably more likely the longer you're on the drug. I mentioned I was on it for 15 years, so I'm different from someone who's been on it for 3 months. And they experience dizziness and panic attacks, and sometimes trouble walking in a straight line. They get dizzy, and they go back to their GP and they say, look, I feel awful. What do you think is going on? And the GP almost inevitably says, you must have had a return of your condition. This shows you must need the drug. Then the person says, but hold on. Sometimes they say this if they've got enough presence of mind. I'm dizzy. I'm unsteady on my feet. I went on this because I was depressed during my PhD. I wasn't dizzy. And the doctor says maybe he's got the flu as well, or maybe it's unrelated, because doctors are very well trained in spotting relapse. That was all through our teaching and all through textbooks, and not very familiar with withdrawal, which has been downplayed by the industry that produces the drugs and by academics that work with industry for many years. And so it's very, not prominent as it was not in my education. And so the doctor ended up saying, look, this is relapse, you must need the drug. And the person walks out and thinks, but hold on, all these symptoms, it doesn't make sense. I became dizzy and I had trouble walking a straight line a couple of days after stopping the drug. It can't be a coincidence. And that's why they go to Google to see, hold on, is it just me or is it other people? And it's when they find the groups, like I had found the groups. And so, yes, that's, and then they're put back on the drug by their doctor. And if they don't work it out, they may stay on the drug for the rest of their lives sometimes.
Right. Okay, brilliant. So just building on from that. So there's two things that I want to touch on. So let me pick on another kind of quite common condition that I'm more of an expert in. So I'm more on safe ground here, which is ADHD. So ADHD, people who have ADHD, the frontline treatment is medication, psychostimulants, and they differ from antidepressants, I think, and correct me if I'm wrong, but they can leave the body sort of within the space of a day. So they usually take them quite early in the morning, say 7 a.m. And then by 5 p.m. or even earlier, that medication has sort of left the body, and they may experience sort of withdrawal effects. So it's sort of almost like a rebound effect. So their symptoms are more intense, but that dissipates within, say, a day or 2 or 3. So there's that kind of version of withdrawal effects, but you're describing something different, and you can definitely clarify this. But so are you saying that through the longer term use of antidepressants, and when you come off them, it's not the case as it is in ADHD where they're just sort of leaving your body? It's that there has been sort of neuronal change, or there's been a change in the brain because of this prolonged use of medication. And so the brain has sort of adjusted and adapted to expect this sort of influx of daily medication of antidepressants. And because of that change, that's a structural change, if you like, then, of course, the body will take longer to adjust without it. Is that what you're saying, why we get these withdrawal effects for so long?
Yes, it's the same for stimulants as it is for antidepressants. I'll explain why.
Oh, okay.
So I can't say that I'm as expert in stimulants, but the neurobiology is the same. And I'll give you 2 analogies, and you'll tell me if they make sense. So this is actually a general rule for all psychiatric drugs, for actually any drugs that affect the brain. When you take a drug, your brain when you take it chronically, when you take it every day for a long period of time, and I'll tell you why stimulants are different from antidepressants, but this still operates. Your brain will accommodate to the drug because of homeostasis. When it's too hot outside, we sweat to become cooler. When it's too cold outside, we shiver to become warmer. We want to stay in the middle. So if you take a drug that increases serotonin abnormally in your brain, you have more serotonin than your brain is used to. Over time, the receptors for serotonin will become down-regulated. They'll become less sensitive. Now, if you're taking the drug, you're in a kind of new equilibrium. There's more serotonin there, and your receptors are less sensitive, so you're somewhere in the middle. When you stop the drug, it's not how long the drug takes to leave your body that causes withdrawal effects. It's how long your brain takes to go back to its normal state. So I'll give you an example. When you walk into a loud concert, the noise is very high and your eardrum becomes less sensitive to noise. It mutes it. When you walk outside into the street, you know everything sounds very muffled for a few minutes. The sound, as you walk out of the concert, disappears in 2 seconds. The reason why it lasts a few minutes, hearing people talking around you muffled, is because that's how long it takes the eardrum to go back to its normal state. So it's how long it takes the brain to go back to its normal state, not how long it takes the drug to leave the body, that explains how long withdrawal effects are. Another example is the bends. You go deep sea diving, you get used to high pressures, you can just shoot up, but it's the time it takes your body to readjust the levels of pressure to explain how long the bends can last. The same is true for stimulants. Stimulants will increase where it is noradrenaline, the body will become less sensitive to it. Stimulants will cause less adaptation of the brain because of what you said. It only lasts for a few hours, so your brain gets a break. Then you take another dose, you get a break, whereas antidepressants generally have longer half-life and they're acting all the time. And that's why they probably cause, you're correct in saying, much more profound withdrawal effects than stimulants. Although some people who use stimulants can have longer withdrawal effects than just a couple of days. And although the drug leaves their body in just a couple of days, the effects on the brain can last for longer. But you're quite right, it's much less severe and people have much less trouble coming off stimulants than they do antidepressants. I think that doctors also miss that point, that it's not the time, because they often say someone will come in and they've been off an antidepressant for 4 weeks and they'll say, I still have terrible symptoms. I'm dizzy, I feel I'm having panic attacks. And the doctor will say, but the drug is out of your system now. It can't possibly be because of the drug. And it's a misunderstanding of what causes withdrawal effects, because the effects on the brain can stay for longer than just the few days it takes the drug to leave the blood. There's definitely an effect of long-term use. So of course, if you've been, just take caffeine, if you've been drinking coffee for a week, it's much easier to stop than after 10 years. So your brain gets more and more used to a drug the longer you use it. So we found in a few studies, there's definitely a relationship between withdrawal effects and length of the time you're on an antidepressant.
Interesting. I guess just to finish the stimulant story, I am aware that people do report the effect wearing off after 5 or 6, maybe even a few more years. So I think the brain does gradually build up a tolerance to the extent that it's no longer effective or as effective. But yeah, it seems to be different speed than, say, antidepressants. So that's really clear. So I just want to touch on this distinction between depression symptoms that's seen in relapse versus withdrawal symptoms. Is there a way to distinguish them? Are they quantitatively different? How would you make that distinction?
Okay, so it can be difficult. There's a few kind of guide points, and then there's some complexity. I'll go to the simpler bits first. So a few ways to help distinguish are the timing of symptoms. So if you have symptoms that come on a few hours or days after stopping or reducing an antidepressant, it's very likely to be withdrawal effects, because as the drug leaves your body, the brain is sort of screaming out for what it's used to, and it can come on quite quickly. We know people who will just miss one dose, they can feel withdrawal effects. Relapse, return of someone's condition, shouldn't happen so quickly. There's this idea that there's this kind of periodicity. Everyone has a certain inborn periodicity. Maybe they have an episode every month or every year, more likely every year. So it'd be quite a coincidence for them to have it just the day after they stop their drugs. Normally it's delayed by a few weeks or months. The proviso to that is, and this is another point that causes a lot of confusion in the clinic, is withdrawal effects themselves can be delayed in onset. So although most of the textbooks say withdrawal effects come on in a few days, because that's the time it takes for the drug to leave your body, we know that people report symptoms that come on weeks after stopping. For one drug, it's quite easy to understand why that is. So Prozac or fluoxetine has a half-life of a week or two, or it's one of its metabolites does. That means it lasts in the body for the body to reduce the amount of fluoxetine in the blood, it takes a week or two. And so it can take a couple of months for it to leave the body. And you can see why that would lead to delayed onset withdrawal effects. It could take a while for you to get down to that level. But it happens for drugs as well with shorter half-lives. And there's one study that casts some ideas on why that might be, which is the drug sticks around in the brain for longer than it seems to in the blood. So they've done PET scanning, and they show that the serotonin transporter, one of the major targets of antidepressants, shows a reduction in effect that is slower than it takes for the drug to leave the blood, meaning it might be sticking around in the central compartment longer than we think by looking at peripheral blood. But it causes a lot of confusion because someone walks in and says, I've stopped antidepressants 4 weeks ago, and now I feel terrible. And the doctor, and I understand why, because I've never heard of this, says, well, that can't be withdrawal effects. That must be you coming back. So it is complicated. The second way to distinguish the difference is to look at the symptoms that come along with it. So I gave a kind of example. If someone comes in with dizziness, trouble standing up, vertigo, headache, brain zaps is this very kind of distinctive symptom where people feel this little zap going through their heads. It can be very unpleasant. It can be on moving the eyes. It's a very kind of classical withdrawal symptom from antidepressants. And alongside that, they feel low in mood and they're having panic attacks. To have all those symptoms together makes it much more likely to be a withdrawal syndrome than to be relapse. Some people argue it could be both. You could be relapsing and have withdrawal effects. I guess that is possible, but in medicine, we use Occam's razor, and we'd say it's more likely for there to be one condition causing multiple symptoms than multiple diseases or conditions to occur at the same time. So I think that's one of the best ways to work out what's going on, to see other symptoms. The other addendum to that is, even if it's psychological symptoms the person's experiencing, if they're different or much worse than the original condition, that also suggests withdrawal. So, for example, actually the most common symptoms are psychological symptoms. I had panic. I'd never had a panic attack in my life before. I'd felt depressed before. So, if you're just scanning quickly as a GP and thinking, the guy's panicking, he's clearly a neurotic, it's probably a return. If you think about it, why has it come on for the first time in my life, or the first time in the person's life, just after stopping antidepressants? Have I developed underneath antidepressants a new panic disorder? It's possible, but it sounds a bit far-fetched. Or am I having a kind of a common withdrawal symptom listed on all the different lists of withdrawal symptoms coming off it? So, I think I use that a lot. Someone went on the drug because their mother died and they were very lethargic and depressed. And now they've come back 4 days after stopping antidepressants and they're panicked and they're having anxiety and they're not sleeping. Those symptoms are very different from what they had before they went on the drug. And it seems more likely that those are withdrawal effects rather than coincidental new onset of an anxiety disorder that just happened to coincide, with that day. So that's the second one, I think probably the most important one. And the third one is, if the drugs are restarted, especially soon after people report these symptoms, they often go away quite quickly. If it's a withdrawal syndrome, it can take longer. If it's a return of someone's condition, it all gets a bit more complicated the longer you wait after restarting antidepressants. But if you do it soon after stopping, withdrawal effects will go away fairly soon, most of the time.
So what you're describing sounds a little bit, and I know what I'm about to say is wrong, and this is sort of to tee you up, but it's, to the layperson, this would be akin to sort of like an addiction to antidepressants. But I know that there is a distinction between addiction and physical dependence. So would you mind just making that distinction clear to people? Because there's obviously a lot of stigma around it, and people don't like to feel as though they are addicted.
Yeah, good question, Sam. It's worth asking that because people get confused about it. So, people are not addicted to antidepressants, but they are physically dependent, and those things mean different things. So, physical dependence is the physiological expected process that occurs after chronically using a drug that affects the brain. Your brain, it's the process I described about homeostasis. The brain will adapt to the presence of the drug. Because it adapts to the presence of the drug, that often causes tolerance, because the other side of withdrawal effects is you become tolerant to the drug. And physical dependence means that when you stop the drug, you'll get withdrawal effects. So probably everybody in your audience will be physically dependent on caffeine. Not going to be causing a big trouble in their lives, but if they stop caffeine, they're likely to get headache and some other withdrawal effects. What they don't have, most likely, is an addiction to caffeine, because addiction means physical dependence plus psychological dependence. And psychological dependence involves craving, compulsion, use despite harm. So people in your audience will not be stealing caffeine from their neighbors or holding up banks to get caffeine or injecting it. So they're not misusing it, they're not abusing it, they're not addicted to it. The same with antidepressants. People don't snort antidepressants, they don't steal antidepressants, they don't take more than they're prescribed. But just by taking it every day, their bodies are becoming accustomed to it. And that's what physical dependence is, and it predicts withdrawal when they stop. Just make one point. The reason why dependence and addiction are often used interchangeably in common language and even in medical text actually emanates from a decision made by the DSM-3 committee many years ago. They were describing addiction, and people thought it was a pejorative term, and they decided to use the word dependence instead. It was actually a very close vote. And that mixed up these two terms that have very different definitions in pharmacological texts. And so people now use dependence and addiction to mean the same thing, but they're not. In pharmacology, they're different. And it's quite correct to say antidepressants are not addictive, but they still cause these withdrawal problems.
Fascinating. Gosh. Right. So what I would want to move on to then is I know that you have a clinic in London that helps people come off antidepressants, and you also have a private clinic, Ultra, I believe it's called. So I wanted to spend time sort of going over advice on how one navigates their sort of with coming off antidepressants. But before I do that, I just want to talk briefly about antidepressants and the side effects during taking them. Because I know you've got personal experience in that, which triggered you to sort of consider coming off. So just talk a bit about that, and just, I guess, what you've learned from other people who are willing to go through those side effects because they fear of either withdrawal or the return of their depression.
Sure. So there are a lot of side effects, which in some ways are misleading. I prefer to call it adverse effects, because side effects, sort of makes it as a side issue, but some of them are actually more common than the positive effects. But anyway, if you go through the pamphlet that comes with the antidepressant, you'll see that there are dozens of effects. And I think most doctors are a bit taught, like I was, to sort of not go into it in depth, say, oh, it might scare patients off from using it. It's written by the lawyers. I think I spend a lot of time in my clinic showing people those kind of leaflets, because I think they're important. A lot of people have those side effects. They're written by the lawyers. That means it's serious. And in fact, they're based on short-term studies, and people may have more trouble in the long term. So they may even underestimate the risk of effects. Some of the effects include sexual problems. So in studies, more than 50% of people on antidepressants will have some sort of sexual problem that involves either erectile dysfunction, difficulty achieving orgasm in men, or difficulty achieving orgasm in women. We know that for a portion of people, that those problems will persist after stopping antidepressants, what's called post-SSRI sexual dysfunction, that's now recognized by the European Medical Agency, and it's put inside the pamphlets of antidepressants in Europe. It's mentioned in England in very kind of understated, maybe typically English style, that sexual effects can persist after stopping for some period. We don't know if that's permanent. It can last for years in some people. Other effects include emotional numbing, again, in about half or more. Sometimes up to 80% of people who are on antidepressants will report emotional numbing. And what they're talking about is their emotional range is restricted. Both negative and positive emotions are reduced in intensity. And of course, that could be very positive for some people to have their anxiety and panic and depressed mood attenuated. But the other side could be very negative if they lose enthusiasm or affection for people around them. We know it can affect people's intimate relationships and their quality of life. And it's one of the main reasons people want to come off their medications. Over the long term, antidepressants have been associated with weight gain. They cause disruption to sleep. So in lots of studies, antidepressants will disrupt sleep architecture. So that sort of normal REM 1, 2, 3, 4 is disrupted. They can cause cognitive impairments, memory, and concentration difficulties. I should say, while I'm saying this, some people say, oh, some of these things are due to the depression itself, but there are studies that have shown that that's probably not the case. So, for example, they've shown that emotional numbing occurs even in healthy volunteers put on antidepressants only for 3 weeks. And the same with concentration and memory difficulties have been shown also in healthy volunteers. Other effects include some people can feel nauseous. I mentioned weight gain. There's quite a wide variety of issues. Some people say they drink alcohol more when they're on antidepressants. Then there's another side looking at long-term health consequences of antidepressants. Basically, there are no long-term randomized controlled trials of antidepressant versus placebo looking at health consequences. So all that we have are observational studies looking at people who are either on antidepressants or not on antidepressants. And they all show similar things, which is a doubling of mortality in people who are on antidepressants, a doubling of cardiovascular disease, a similar increase in strokes, an increase in osteoporosis, an increase in cataracts, an increase in falls in older people. And there's a debate about whether those increases to the physical health are due to the antidepressants or the underlying disorder. And there's an argument both ways. Even if it's only partially due to the drugs, some of those impacts are significant, impacts on heart, stroke, and early mortality. So there's a variety of different long-term risks and then and adverse effects. And how do people weigh them up? It's interesting. So, some people conclude that's the price of admission. I feel, I don't have erections as much, or I don't feel sexual attraction. That's worth it because of the positive effects to my emotions. And other people don't think that, and it changes over time. So, for example, emotional numbing might be very useful in the short term. People find that, a relief from their symptoms, but 3 years down the track, they're in a better place, and they want to feel more for things around them, and so the balance shifts. It's clearly very individual. I think another thing which I find is in my clinic, when I show people these lists of side effects, they're surprised. So they say, I have this, but I never thought it was the drug. And the reason why I think that happens is it's not like antibiotics. When you take an antibiotic and you feel nauseous after 2 days, it's obvious what caused it. But antidepressants are more subtle, and people take them for longer. So if it makes you a bit numb, you may not even notice it because, one, you can't remember exactly how did I feel 15 years ago before I started the drug. And it sort of may fade into the background of lots of things that happen. So I think a lot of people are surprised to see symptoms that they experience are listed on the side effects of the drug information leaflet. So I think maybe people are not aware of or don't put it together.
Yeah, and we don't have to talk about this, but I know this sort of links back to your personal story because I read or saw somewhere that you were attributing sort of symptoms or changes in your behavior to you weren't attributing them to the antidepressants. So I think you had sort of daytime tiredness and
exactly. So I had profound problems I had severe daytime tiredness. I'd fall asleep during the day. I had worsening memory and concentration. I was once very, had a very sharp memory, and it deteriorated badly. I didn't attribute it to the antidepressants. I didn't think of that. I saw doctors, and I ended up being diagnosed with various conditions. The main ones being chronic fatigue syndrome, and then I got a diagnosis of narcolepsy, a sleeping disorder. There was always a little bit of hand waving about it, but that was the diagnosis that I was given. And so I was very surprised when, as I came off my antidepressants, that those symptoms improved a lot. Daytime tiredness, memory and concentration all improved. And so it wasn't really until I was in the process of coming off them, this is sort of 16, 17, 18 years into being on them, that I understood that there was a connection between those symptoms and use of antidepressants. And that's when I looked at the literature that antidepressants disrupt sleep architecture, and it made a bit more sense to me. So I think, and the other thing was, I came across a lot of people saying similar things. People who were on antidepressants who said, yes, since I've been on them, I have a 2-hour nap every day. And that really sort of put a little green flag up for me.
And again, not to probe a bit more, but wasn't it a case that you were considering early medical retirement, or?
So I ended up, I saw, because I was diagnosed with narcolepsy. So number one, maybe I should emphasize the point. I didn't have a little bit of trouble concentrating, a bit of tiredness. It was very impairing to the point where I was working part-time. So I worked part-time for many years. I saw doctors for narcolepsy. I ended up getting more medication. I was put on more stimulants and other psychiatric medications. And it got to the point where my memory and my concentration and my ability to stay awake during the day was so impaired that I was looking into retiring. I was in my mid to late 30s at that point, and I was so unwell and finding it so hard to stay alert and to do my job that I thought that it was becoming dangerous. That I was walking around basically writing things on a piece of paper that people told me if I lost that piece of paper, I couldn't remember what patients I'd seen. I thought this is becoming irresponsible, and I was looking into taking medical retirement. That was a point where I took a break from my training, and that's when I actually started coming off my drugs. That's when sort of began this. So yes, the effects of the drugs on my ability to function were profound.
Wow. Yeah, that's something to hear. Sorry to sort of pause, but I know that you want to go off at 11, so it's now 10:30. If you wanted to leave like 5-10 minutes just to stretch your eyes, that's fine. But what we can do now is we'll just sort of ease into the home straight. So we'll what I wanted to talk about now is you've got Joe Blogs or Jane Doe. They're on antidepressants, and they may fall into one of two bins. I mean, I'm sure there's many different bins, but there will be those who are perfectly fine on antidepressants, but they may hear just how bad they are and be averse to taking them any longer. And then those who are in a similar situation with you, where their price of admission, they have doubts about whether that price is worth it. And so they might want to come off. So I guess if you could speak to those two people, are you saying like everybody should come up antidepressants, which I know is like a caricature, but yes, I guess that's a question that is begged from what you're saying.
So I'll say a couple of things. So number one, my message out there is not to everyone to stop your antidepressants. That's definitely not my message. My message is to be informed about the effects, the negative effects, the positive effects, the alternatives, and how to stop safely. That's what I seek to inform, not to tell people what to do. People can make decisions for themselves. And my second message is, whatever, hearing this podcast or something else, do not stop your medication abruptly. Do not stop it in a day. I'm definitely not saying that. I'm saying the opposite of that. To summarize what I'm going to blather on about for a few minutes is come off your drugs slowly, and ideally see your doctor to get some supervision. So I'm certainly not telling people to throw their drugs in the bin. To talk kind of, I guess, from people I mean, so I'm not going up to people and saying you should come off your medication. So maybe let's talk to the second bin or the second group of people about how they might think about it. And maybe we, maybe people in the first category, we'll take some ideas from this. So, so number one, what I do in my clinic is to let people know what the benefits are, what the adverse effects are, what the alternatives are, and how to stop safely. So I talked a lot about relapse prevention properties of antidepressants, why they're used in the long term, and why that evidence may be fraught. And often what people will say in my clinic is, you're describing me. I tried to come off and I did have all these panic attacks and I hadn't had them before. And I was told it was relapse. And now that you say it, I'm thinking it was quite strange and maybe it was withdrawal because I did come off very quickly. So, even that kind of abstract story makes sense to people. I didn't go at length on the short-term benefits of the drugs, but I often mention that. Very briefly, the difference between placebo and antidepressant is very small. Everyone agrees that it's a small effect. Some people say it's on the higher end of small and on the lower end of small. The studies for short-term effects go for a very short period of time. So the difference is on a 52-point Hamilton Depression Scale, it's a 2-point difference between placebo and antidepressant. So over 6 weeks, if you take a placebo, you get about 8 points better. And if you take an antidepressant, it's about 10 points better. There's a few issues with the way the studies are done. People are unblinded. They know they're on the drug, and that can make people respond more positively because they think, oh, I'm on the drug, I'm going to get better. The studies only go for 6 to 12 weeks. We know that there are tolerance effects because any drug that causes withdrawal effects, the flip side is tolerance. So the drugs will get less and less effective over time. Sometimes in these studies, people are taken off antidepressants before they start, and withdrawal effects from coming off before the study starts can make them look worse in the placebo group, but the withdrawal symptoms are improved by the people who put on the drug group. There's a publication bias. We know that about half of studies aren't published. And so the difference may be even less than 2 points. There's a debate about, are there some people that have a much bigger response, maybe a minority of people, and none of this takes into account unblinding and how short the studies are. So in other words, I think everyone would agree that for most people, these drugs are not highly effective. And it may be the case that for most people, they don't do anything at all. The numbers needed to treat, according to one way of looking at it, is about 6 or 7. That means that for 6 people given antidepressants, 1 will benefit and 5 won't. So there's limited evidence for effectiveness, almost whoever you ask, even if you think I'm being a bit negative. Then I often will show people a list of the side effects of their drugs, and I will pull out the patient information leaflet. And sometimes people will tick off 15 symptoms. And I ask them the question I've sort of put to you, are the beneficial effects of the drug worth it? And some of them say, yes, I don't mind. Some of them say, no, I really want to stop it. And then I talk about alternatives because people are always thinking, look, they went on the drug for a reason. So, they were like you, like me, depressed or anxious. And I talk through ways of thinking about that. And the first thing that I would say is, some people call these things a chronic illness, but another way of looking at them is a response to stressful circumstances. And we know the data on that is very strong, that if you know the number of stressful life events in someone's life over the last year, you can predict their risk of depression with great accuracy. The lines are incredibly, the relationship is incredibly steep. I've never seen, my biological colleagues don't like when I say, if you look at neuroimaging and chemicals in the brain, you never see anything much more than a flat line between depressed people and controls. But if you look at stressful life events, you see this incredible correlation, these huge steep lines. Your story, doing a postdoc, I was doing medical school, relationship problems, insecure jobs, poverty, cost of living crisis. I don't need to spell it out for people living in the real world. And when those stressful events get on top of you, they overwhelm your ability to cope. At some point, you sort of fall apart. That's probably what being depressed and anxious is about. And those things can pass. You change relationships, things change. And so to interpret that as having a chronic anxiety disorder that's lifelong or a depressive disorder that's lifelong, it may be an incorrect framing of things. And a lot of people, inevitably the story comes out. They had young children and they were working 2 jobs and they were stressed financially. Their wife had just left them. There's often a reason why people fell into a heap. And now we're 3 years later, 5 years later, sometimes we're 30 years later. And so, then the question is there anything there to be treated? Maybe there's a predisposition. Maybe, you're a bit anxious or a bit depressed. And then I tell them as well, in a study that followed people for 45 years so far, by the age of 45, 86% of people met criteria for mental illness, and 70% of people met criteria for an anxiety or depressive disorder. In other words, it's more common to have one than not to have one. I sort of go through my friends and family. There's one guy I know who's relentlessly cheerful, but everybody else has had a very difficult time in their lives. So it's not that unusual. I think it's, in my view, depression and anxiety is more likely to be the response of a normal brain to stressful events than evidence of an abnormal brain. And I think telling people they've got an illness or a chemical imbalance plays into this idea that there's some sort of abnormality in them they need something extra for. So I spend some time talking about different ways of looking at it. Some people are very attached to their diagnosis, and I'm not going to, rip it away from them, but I talk about other ways of looking at it. And that can sometimes, you can sort of see people thinking, yes, I did think it was just transitory. It's interesting how withdrawal plays into that. Because if you think you've got a brain problem, an illness, a chemical imbalance, then you come off your drug and you feel terrible, it can confirm for you that you do have something wrong with you. So it's interesting how withdrawal plays into people's pre-existing concepts of their condition. And so unpicking both of them, I think, is important for people to make sense of this area. And then I mentioned, sometimes relevant to patients that I see, there are lots of other things that are effective for depression and anxiety. The first thing I would say is, the most cost-effective treatment for severe depression, according to NICE, is problem-solving therapy. And I think that's very kind of illustrative. It's the problems in people's lives that that cause them to be depressed. I'm not going to pretend that I'm some master psychotherapist. That's not my skill set. But the idea that there's some sort of a chemical thing and we give a chemical drug to everybody and that fixes things is a very simplistic idea. Every person has a particular set of issues that have particular solutions. And so there is a list of treatments in the NICE guidelines, different forms of therapy, mindfulness, exercise, that are found to be as effective and as cost effective as antidepressants. And sometimes people will pursue them. So those are some of the alternatives that I'll talk through. And then I would talk about how to safely come off antidepressants if they decide to. So this is information for them to make their decisions. The people coming to me are often already want to do it or pretty interested, and I talk through how to do it safely. And I guess there are 3 main principles to coming off an antidepressant safely. Number 1 is to do it gradually. Gradually means generally months or more than a year for long-term users. So I'm not saying for everybody, if they've been on the drug for 2 weeks, they're not going to be in my clinic. Most people who've been on it for 2 weeks can stop in a few days. But because the NICE guidelines recommend people be on the drugs for months or sometimes years, everyone I see has been on them for a long time, more than a year, more than 2 years, sometimes more than 10 years. So that's what I'm really talking about here. And there are observational studies that now show that people who come off more slowly have a better chance of staying off than people who come off quickly. So that's number 1. Number 2 is going at a rate that they can tolerate. So I've done some work on how do you guess who's got the biggest risks, but really there's not the data to say, you, Joe Bloggs, you're going to take 18 months and Jane Doe's going to take 27 months. We don't know that. So the only way to really work it out is to do a test reduction, see how they respond, and use that to adjust the rate. If it's going fine, keep going. If it's too much, go back, wait, go much slower, or if it's a bit in the middle, slow it down a bit. So you've got to adjust things to how people tolerate it. And that involves, just thinking about a GP watching this, it involves more work. It is more trouble because if you just say Harvard and Harvard, they're out of your office. So I sort of realize that I am making things a bit more complicated for people. But the benefit is people can come off these drugs if they do it in this way. So you've got to be a bit individual. And then the last bit, is a bit of neurobiology, which is I'm gonna inflict graphs on your listeners in a second. I apologize in advance. It's a bad habit of mine. Actually, I'll just do it now. Let's just break the seal. These are some slides I prepared earlier. So this is an important point to see. This is a graph from a neuroimaging study, nuclear imaging, where they looked at the effect of citalopram, a very common antidepressant, its effect on the serotonin transporter, but for less neurobiologically inclined viewers, it's really just effect on the brain. It actually relates to all sorts of receptors. And the key point is it's not a straight line where doubling the dose doubles the effect. So 20 milligrams doesn't have double the effect on the brain as 40 milligrams. In fact, they're quite close. The reason why you get this shape, which is called a hyperbola, is because when there's not much drug about in the system, every extra milligram has a large effect because all the receptors are available for it to have an effect. As there's more and more drug, every extra milligram has less and less effect. It's kind of like musical chairs. As the chairs are taken away, every extra person has less chance of finding a chair. And so I'll tell you for people who don't know, 20 milligrams is the most commonly prescribed dose in England, and some people are on 40 milligrams. Straight away, you can see a tiny dose like 2 milligrams has almost half the effect of 60 milligrams, a bit less, maybe about a third. In other words, very tiny doses have very large effects. And I'll show you what this means for people coming off their antidepressants. I said to you the most common technique that doctors use is to halve the drug and then halve it again. When you go from 20 milligrams of citalopram to 10, the change in effect on the brain is smallish, and most people can handle that. Going from 10 to 5 is a bit bigger, and that can cause people a little bit of trouble. But going from 5 milligrams to 0 milligrams causes a huge change in effect on the brain. It's kind of like you're walking down a not very steeply inclined path. It turns into a steep cliff, and then it turns into a vertical cliff. And so I think about people falling off this cliff. And because most doctors are not aware of this relationship, they miss this effect, and they see in front of them a person who's in real trouble with panic attacks and anxiety, and they think that they must need the drug. And by the way, this pattern is exactly what patients report. They say the first few milligrams are the easiest to reduce, and the last few milligrams are the hardest to come off. I'll spare that quote. The understanding of this relationship also explains what would be a more rational way to come off these drugs. So in this, I've drawn horizontal lines this time that are parallel. So coming off this drug at even amounts of effect on the brain rather than even amounts of dose mean that you get these rather more peculiar doses, because now it goes from 20 milligrams to 5 to 2.5 to 0.8. And that's because it's following this hyperbola. And that's why people call this a hyperbolic pattern of dose reduction. And what you can see, the doses get smaller and smaller. So there's the size of the reductions, because you're now easing yourself down this steep cliff. And importantly, this final dose before stopping is very small. And it's much smaller than the smallest available tablet in England, which is 10 milligrams. And so while I'm on the topic of making life harder for GPs, unfortunately, and patients, you cannot make these doses by using widely available tablets. And so people have worked out by themselves all sorts of different tricky ways to do it. And there are a few ways that doctors can advise because of what the guidance says. And the easiest way is to give people a liquid version of the drug. So most of these drugs come as liquids. And in that way, people can make these very small doses. And there are a few other tricks people use. You can open up capsules and count beads inside drugs. You can even dissolve tablets in water. It's a perfectly legal thing to do. It's not encouraged by the drug manufacturers, but people do it. And there's NHS guidance about how to do it. And so people need to find ways to make these small doses. And what I've found in my clinic is many people who have tried several times to come off antidepressants in that halving, quartering manner with their doctors and have been unsuccessful are able to come off in my clinic by going down in a much slower way. It takes them a lot longer. The average time so far, I think, is about 18 months. Some people take even longer than that. A lot of them use liquids, and they're able to Some of them are in the process, so they're down to much lower doses than they've ever been on, or they're off their drug. And so this extra bit of effort and cost, because liquids do cost more than tablets, could be worth it in terms of saving people being on these drugs the rest of their life, saving the adverse effects, and maybe getting back. For example, some people might disagree, but I'm a more productive member of society now because I'm working full time. So there are other advantages to being on less medications that affect the brain.
Fascinating. So is there this is me speaking from a strong position of ignorance, because again, to use a personal example, so my sister was taking painkiller medication because she had a slip disc or something, and she's well aware that they can become quite addictive because they were very strong, potent painkiller. And she did a type of tapering herself, so she was on a couple of tablets and then one, and then she made the mistake of halving it, and I think the sheath that the medication was in was deliberately made so that it would be a slow release of the drug. So she just got a full whack of the drug and she was delirious. But is that a case for any of the depression medication where there is it's slow, the shield, sort of what the medication is contained in the outer shell of the pill is designed for a slow digestion rather than you chopping it in half?
So there are a couple of drugs that do have something similar to what your sister experienced, especially for Effexor. It comes as extended release tablets, and I think you actually can split it in half, but I'd have to check the manufacturer's guidance for that. You can't dissolve it in water because it turns into a gluggy substance because you sort of mix up the matrix there. So you're right. I didn't go into that level of detail because I've just written a textbook on how to come off these drugs, and there's 25 different drugs, and they all have different specifications. So, but you're right. You should certainly check, can this tablet be split? Can it be dissolved in water? Is there a liquid available? Those are the questions you've got to ask your doctor or your pharmacist, and to check whether that's safe to do. And you're right, there are risks with manipulating tablets, especially with extended release, if you don't then treat it as an instant release. So if your sister had been aware, she could have thought, this is now an instant release. I need to take a smaller dose more times a day in order to make up for it. But you're right. Once you're starting to change the way these drugs are delivered, you've got to think through the pharmacology, and that's where a pharmacist is going to be very, very helpful for people in this.
Right. So I'm conscious of time. So if I could ask maybe one or two more questions. So one thing I'm interested in is, again, going to ADHD. It's often it's a comorbid disorder, as they say. In other words, you can have lots of co-occurring psychiatric conditions along with ADHD, and depression is one of them. And so it's often the case that you have individuals that are taking many different types of medications. And so I guess my question is quite a broad one. But you don't need to give a very comprehensive answer, which is, what is the sort of evidence of looking at the sort of possible synergistic effects of taking many different sort of medications or psychoactive substances? And, is this ripe for more research, given what you've said about SSRIs?
Yeah. Look, I can't say it's my area of expertise. Drugs interact with each other in lots of different ways. They can affect each other's metabolism. Often there's limited study because you've got to get someone to take, if you're on 4 different drugs, you got to find some study where they put people on these 4 different drugs and compare them to people who are not on those drugs. So it's quite hard to do those studies. So sometimes studies on polypharmacy are theoretical. I think when it comes to ADHD, for example, one thing is impaired concentration is on the patient information leaflet for some of the antidepressants, and there are studies showing that it can affect concentration. So if someone is on that drug and they're on other drugs, so benzodiazepines definitely impair concentration. Antipsychotics can do the same thing. If they're on more than one of those drugs, there might be interactions. And so I personally don't know the studies. It's not my area of expertise, but I certainly think that being on one or more psychoactive psychiatric medications could cause people impairments in concentration and memory that might be diagnosed as ADHD if the person looking is not aware of those issues. So I think that's a very important area to focus on, which is what are the cognitive and emotional and physical side effects of one, and especially more than one drug on people. We know in older people, which you could think of, sorry to use a very cold term, as a kind of sensitive vehicle for looking at issues, that it can cause people a lot of trouble, delirium and falls. Is it possible that in healthy adults who are not as prone to that as older people, are they partially affected by that? Do they have the same? I can say from my personal experience, when I've been on at the same time 5 psychiatric drugs. I could barely think straight. So personally, it affected I'm sure if I'd been seen by an ADHD specialist, I would have got a gold star for having all the symptoms. So I think that's definitely an area to look at.
Thank you. Yes. Okay. So I just wanted to give you an opportunity to just tell people at home what you've got coming up, any areas that you would encourage people to look into, anything that you want people to talk more about. You've mentioned that you have a book coming out, which I've just had a quick Google on. I can see that is it in April next year? It should be released, and you're co-author with David Taylor, looking at the Maudsley describing guidelines. So that's coming up. But is there anything else? And again, anything that you think people should talk more about?
So I didn't know they had a date, actually. That's you're telling me for the first time. So yes, the Maudsley deprescribing guidelines, which is aimed at doctors, psychiatrists, and GPs, but it might be interest to some patients, goes through how to come off every antidepressant and a variety of other psychiatric drugs. So it might be interesting to people. If there's a research kind of audience for this, I think this is an area that is ripe for more research. I think that the adverse effects of drugs have been generally minimized, and the positive effects exaggerated. It's not a conspiracy theory, because of course most of the studies are done by manufacturers of the drugs, and there's an inherent bias. I think there's been a kind of block on looking at the adverse effects of psychiatric drugs. People say if you talk about the negative effects, you're going to dissuade people from taking effective drugs and lead to people having worse lives. I think that you cannot override, informed consent. You cannot make decisions for people. People have to know what the good and what the bad are, and we can't make decisions for them. So I think it's very important to readjust the balance and look at the negative effects of these drugs. If they're found to be positive for some people, fantastic. Then we have a better idea of who that's for how long. I think the withdrawal effects in relapse prevention studies is an important area of research that we're doing some work on. And I think there's a lot of research to be done in this area, and I would encourage researchers to have a look and not be put off by the idea that if you mention the negative effects of drugs, you're somehow doing the public a disservice. I think it's the opposite way around. People need to be informed. And if people want to contact me, I've got an email address at UCL that I can put in the notes. Oh, you're muted. You got that right every time.
So, yeah, I was just panicked because it's approaching 11. So thank you very much, Mark. That is an absolutely brilliant interview, really useful, and I think many will agree. So thank you again. I'm going to stop the recording.